Get the mics and welcome to PharmaDocs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, hello there, John. How you doing?
Hello, Jay. Great.
Good.
How are you?
Doing well. We're just together here for the March 10th episode of PharmaDocs.
PharmaDocs.
Yeah.
I just absolutely love it, Jay. I just look forward to it because, I mean, there's always stuff going on in pharmacology. Okay.
Yeah.
And the way we relate it to pharmacology, adverse drug reactions, medically compromised patients, drug to drug interactions, and even medical emergencies.
Yeah.
You know, it's never a bad thing, Jay, to learn as much as you can about pharmacology and medical emergencies.
Exactly.
You just can't have enough.
Yeah.
You know?
I know.
And there's so much that's coming at us on a continual basis. I mean, it's,
Yeah,
almost like
how many
guarantees
drugs
in life are death and taxes, and also new drugs being approved. I mean,
so
it's coming.
We're going to do 5. How many were approved last month in February? I think it was more than that.
Yeah, we had 11
10.
last month.
11.
Yeah.
Okay. Yeah. It's I mean, and the drugs that are being approved now are really novel drugs, and a lot of them are for diseases that were neglected before. We call orphan diseases and orphans, and now we have our orphan drugs that have been developed to treat some of these illnesses, and they've been approved and they work.
That's right. And not just the orphan medication, but also first time therapy or first in class drugs.
Yeah.
For disease states. That means, technology is just getting greater and greater. We're making so many more advancements now.
Mm-hmm.
And so,
yeah.
And again, Jay, it's just like you see every day and I see every day. And I want to remind our listeners, anybody that's on 5 medications or more, that's called polypharmacy. Okay. Polypharmacy. And, you're going to treat these patients in your office, whether it be for diabetes, hypertension, coronary artery disease, arrhythmias like AFib.
Yeah.
It just the list goes on, and more medications are being created, are developed, and patients are getting stacked with these medications.
Yeah, they're on a lot of meds, and we see these in our offices, these patients every day.
And Jay, we've talked about, I'll just get medical clearance. Well, first of all, let me explain to the audience, there's no such thing as medical clearance. Okay. It's going to be medical consultation. You'll discuss that patient's treatment with his or her physician, because they're on so many medications, but ultimately you, the dentist, you make the final decision to treat that patient.
Yeah. Because remember, the physicians don't really know what you're doing.
That's correct.
They don't know anything about dentistry. And if you're doing surgery, if you're doing, they don't know what a root canal is unless they've had one. And sometimes even when they had one, if they've had one, they don't know what it is. So you really need to educate them about the patient that you're discussing, so you can come up with kind of the best treatment plan, see if you need to modify any medications, modify your treatment plan at all, and be able to deliver the best care to the patient that you possibly can.
And while you're delivering that care, should something happen to that patient, also be able to deliver the best treatment to possibly save a patient during a life-threatening medical emergency.
Mm-hmm. Oh yeah, because those things happen.
And unfortunately, Jay, none of us have a crystal ball. This is why you've got to have that kind of training done on an annual basis. Mm-hmm. Yeah. And I just hope our listeners will take that to heart and develop a plan around that as well. Yeah. So, Jay, what's our first new drug?
Well, our first drug today is Jesduvroq.
Jesduvroq.
Yeah, Jesduvroq. Daprodustat tablets. And this drug is for the treatment of the anemia that is frequently seen in patients who have chronic renal disease and are on dialysis.
Right.
Yeah.
And of course, so Jay, automatically dialysis, we know our patients are either going to be Monday, Wednesday, and Friday, or Tuesday, Thursday, or Saturday.
Yeah.
And of course, alterations must be done to that patient should you be performing some type of oral surgery on that patient as well, too.
It will be on blood thinners.
That's right.
Going through dialysis. So this drug is an interesting drug. It's called an oral hypoxia inducible factor prolyl hydroxylase inhibitor.
HIF5.
HIF5. Exactly. And so basically what happens is in chronic renal failure, especially on dialysis, is the kidneys get to the point where they have difficulty producing erythropoietin. And what erythropoietin does is it signals the bone marrow to produce red blood cells.
That's right.
What happens is their hemoglobin drops very drastically. And, we always think of a normal hemoglobin of being at least, let's say in a male, being at least 15 or 13 to 15.
13.
Yeah.
Right.
And in some of these patients that are on dialysis and with renal failure, you see hemoglobin's down below 6, which is what that means is there's not enough hemoglobin in the blood to get oxygen to all the tissues that need it. And so it's a very dangerous situation for the patient. It can be life-threatening. And so what this drug does is it works by increasing erythropoietin release from the kidney. And it's the first oral treatment that's been approved to treat anemia due to chronic renal disease.
Again, I just said that on our opening statement. Here we go again. Another first drug in its class right there. And, Jay, and then, of course, talking about, renal failure, some concerns, are drug interactions. So when that patient comes to your office and, in fact, you've written a great course, a separate course on opioids and prescribing habits for dentists, and we'll talk about that when that is time is ready to do so. But what are you talking about? Well, don't prescribe the opioid, prescribe NSAIDs. All right. So we see a greater use of NSAID, but we got to be careful on that kidney patient.
Yeah, patients who have renal disease, or if they only have one kidney. Let's say they donated a kidney to somebody. They're going to have decreased renal function, and the nonsteroidal anti-inflammatory drugs, including aspirin, can be toxic to the kidneys. Well, and so you really have to avoid using those.
That's right, kidney, because Jay, right then, the kidneys may be in a hypo perfusion state. Mm-hmm. So the prostaglandin synthesis occurs to increase that renal flow. Mm-hmm. Or that perfusion. And then what happens when you give an NSAID? It blocks prostaglandins.
Right.
So therefore, you're harming the kidney here. So always remember that somebody with renal disease, that by you prescribing an NSAID, you could lead to renal failure.
Mm-hmm.
So again,
exactly, which you don't want to do.
We just talked about medical clearance versus consultation. This is where you'll want to consult the patient's nephrologist to discuss and say, hey, look, I'm only giving this for a few days, and y'all discuss the case and then come up with a prescribing plan for this patient after you perform some type of surgical procedure on them.
Exactly. There we go. Dog tangled in my earphone cable.
But Jay, also not just the NSAIDs, but also tetracycline or minocycline. And tetracycline is something we prescribe as well too, because an accumulation of tetracycline can increase the BUN, blood urea nitrogen. Right. But just because you had an increase in BUN doesn't mean you're going into kidney failure. You may be on a high protein diet, or you may be dehydrated. Exactly. That's one of the best signs. GFR, or glomerular filtration rate, or the creatinine clearance, is a much better lab to determine what's going on as far as renal failure is concerned.
Yeah. So one of the big issues with Jesduvroq sometimes does such a good job inducing erythropoietin release that the hemoglobin will go up too high or too fast. And that's also a dangerous situation because that can lead to a thromboembolic effect, like a heart attack, stroke, pulmonary embolus, an arterial obstruction due to a thrombotic event. And so doctors who are prescribing this have to be really careful about the dose, and they really have to look at the dose well. And they've noticed that the thrombotic events occur much more commonly once the hemoglobin gets above 11 grams per deciliter. And so it's recommended that with this drug that they only give enough of the drug to get the hemoglobin in the 6 to 10 milligram per deciliter range.
Okay, so
because of the risk of these effects.
So that's great what you just said. You said the doctor is prescribing this. What about the dentist treating this patient, Jay? So, I mean, that's a very fine line right there. So bottom line is, from all that great stuff you just shared with us, we, the dentist, if we're treating this patient, what's the most important factor we need to know? We need to know the hemoglobin levels on this patient.
Yeah. Yeah. And because obviously we want to make sure that they are in
not too low or not too
low,
high.
too high. Exactly.
That's right. I mean, great point there, Jay. I mean, so again, this is something else. Like when this patient comes in on Jesduvroq, so we've got to know, hey, I remember those guys on PharmaDocs saying something about this.
Yeah,
absolutely. Just don't go charge right in there and start treating this patient.
Yeah. Some of the other side effects that are not too good are the fact that if you have a patient who has a history of heart failure or has mild heart failure, this drug can make it worse. And same thing with hypertension. It can make their hypertension significantly higher.
Right.
Or if they have any erosive GI disease like esophagitis or peptic ulcer disease, it can exacerbate that, especially if the patient smokes or drinks alcohol, and if they've had a history of ulcers before. So it's a great drug for what it's indicated for, but there are a lot of significant adverse effects that the clinicians who are prescribing it need to be very aware of. And this drug is metabolized through the liver, through the cytochrome P450 system, specifically the cytochrome P2C8. And so, as you would guess, drugs that are inhibitors of cytochrome cytochrome P2C8, if they're an inhibitor, that will reduce the metabolism of this drug, which will increase
the levels up. That's right.
And these are drugs like gemfibrozil, which is Lopid, which is given for high cholesterol, and a drug we see all the time, clopidogrel, which is Plavix.
Yeah.
Very, very common. I think a patient on it today, 2 patients on it today. And so they have to be aware of all that. There's some other drugs that also are potent inhibitors, but they're not really drugs that we prescribe in dentistry. So we'll just kind of gloss over those.
But Jay, the thing about it though, like I just said in the beginning of our segment, we're talking about polypharmacy.
Yeah.
We're going to see patients with all these medications. Okay. All right?
Yeah. They're going to be coming in more and more.
And then they're on Jesduvroq. All right. Now, okay. So they might be on Plavix, felodipine, because that's a calcium channel blocker.
Yeah.
Or it could be a ARB, an angiotensin receptor blocker, candesartan. Those are very common drugs. So now you've got to realize they're on that drug, this drug, and what it does to the cytochrome P450 system. It inhibits that. So now you got to increase level of this drug. What happens when we get the increased level? That means we could wind up with an increased hemoglobin.
Right. And a thrombotic event in
your
office. In your office.
You're
treating this patient. Yeah.
So to the audience out there, look at the pathway we just took you just on one drug. And then we had to think about the cytochrome P450 system as well too.
Yeah. And there are other drugs that are inducers, which of course would drop the level. And kind of the most significant is with rifampin.
Rifampin, yeah.
Yeah. Which, is given, it's basically like a kind of an antifungal that's given to patients with severe fungal disease. So when you have a patient in renal failure, let's see, we went through all that. There are drugs that are okay to give with a patient. If you have a patient in renal failure or chronic renal disease or on dialysis, there's some that are okay to give and some you absolutely need to avoid. And as far as antibiotics go, tetracycline, minocycline are drugs to be avoided with renal failure patients, as well as we mentioned earlier, the non-steroidal anti-inflammatory drugs, and then aspirin. Now, fortunately, the drugs that are safe are most of the antibiotics we use: penicillin, cephalosporins, azithromycin, metronidazole, Cipro. Although in a couple of those, the dose has to be adjusted. But as far as analgesics, acetaminophen, and if you do give narcotics, you do need to reduce the dose. And same thing if you're doing sedation, you need to reduce the dose.
Absolutely.
Yeah. Yeah. All right. So speaking of high blood pressure.
I'm glad you went back to that.
Yeah.
Because this is the latest guidelines out there.
Yeah. Yeah. And so a lot of people look at that and say, oh, if my blood pressure is 123/81, you're in the elevated range, which is something pretty new. So normal, less than 120 and less than 90. And of course, over 140 and over 90 would put the patient in stage 2 hypertension. So not just mild, but pretty moderate. And then of course, if you have a patient who comes in and they have a systolic over 180 or a diastolic greater than 120, that's a true medical emergency. And you need to contact the patient's physician right away to see what they want to have done. They probably want to have them sent to the emergency room to get that blood pressure down.
And document that you did do that with the patient.
Yeah, exactly. All right. So let's move on to our next drug, Lamzede, Velminase alpha, lyophilized powder for injection. And this is a recombinant lysosomal alpha manosidase, which is indicated for the non-nervous system manifestations of alpha manocytosis, which of course is a concentration of mannose-rich oligosaccharides that is too high. And so this is it's basically a storage disorder. You've heard of other ones in dental school where you have abnormal storage of different carbohydrate metabolites. And what this does is it interferes with development on all fronts. And patients who have these conditions will have all kinds of neurological manifestations, such as hearing loss, speech difficulty, developmental difficulty, visual problems. They may also get chest and ear infections frequently because it affects the immune system also. And so the deficiency is in the MAN2B1 gene. And what this drug is, it's not an inducer, it's not an inhibitor, it's actually recombinant DNA enzyme replacement therapy that's given intravenously once a week.
Once a week, that's right.
And it will get the mannose levels down. Now, one of the big problems with this, or one of the big side effects that's significant, is a significant transfusion reaction that occurs fairly commonly. And with transfusion reactions, we see things like fever, chills, arthralgia, rashes, and if sore throat. And if it gets really bad, the patient, or it can be so severe that the patient goes into anaphylaxis. So that's one of the things that.
Jay, on that right there. Okay, so the one thing about Lamzede, it clearly states a common adverse reaction includes anaphylaxis. Common.
Yeah.
Okay. Not just quote rare. Okay. But a common or anaphylaxis, headache, arthralgia. So I mean, think about that. Because again, this is another one of these first drugs ever for
for orphan disease.
That's right.
Yeah. Now you're not going to experience this in the office.
No.
With a patient, it'll be where they get the where they get the
their
injection.
Infusion. That's correct. But again, like we said, with so many dentists out there, Jay, and then watching our program, they may have somebody that is affected with this rare disease.
Yeah.
Okay. All right. And they may we have a new treatment called Lamzede, and you'll be undergoing this. Hey, I remember those guys talking about that.
Yeah. And so it is been shown to be effective, but it does have some significant side effects.
Again, it's an enzyme replacement therapy.
Right, exactly, which is different from most of the drugs we talk about. The next one is Filspari.
Yeah, because they all depend on the enzymatic pathway.
Right.
All right. Because they come in as a substrate, and then they're either could be approached by an inhibitor or an inducer.
Yeah.
Which will either increase the levels of the drug or decrease the levels of the drug.
Exactly. So the next drug is Filspari, sparsentan. Sorry about that. And this is another unique drug that is a dual endothelin angiotensin receptor antagonist. And what this is indicated for is to reduce the proteinuria that's seen in primary immunoglobulin A nephropathy. So what's happening in that disorder is that these accumulations of immunoglobulin A, IgA, are accumulating in the kidneys and interfering with the filtration functions and actually affecting the kidney itself. So you get declining renal functions in these patients. And it's one of the leading causes of renal failure, actually. And patients that have this disorder will have blood in their urine. They may have protein in their urine, and then a progressive loss of renal function, which can lead to edema and hypertension.
So it's hematuria,
proteinuria.
Yeah, that's right.
Yeah. Okay. And so the other thing about this drug is it has been shown to reduce the proteinuria. Okay. But it has not been established if it actually slows progression of the renal function decline. And so this drug was granted approval under the accelerated approval program, which basically means in going forward in the future, its future approval will depend on studies that show that it actually is effective. So we know that it's safe, it does what it's supposed to do. But as far as progression of disease, it's not really clear yet how effective this drug is.
So, Jay, when somebody walks into our office and they're on Filspari, we can't overlook that. This is a sick patient. This is a patient that has progressive kidney disease.
Right. Yeah. So this is another set of patients where you're not going to give them non-steroidal anti-inflammatory drugs. And there are, other drugs that can affect this drug too. Even antacids and acid-reducing medicines can decrease the effect of Filspari. So, patients, I'm sure, are warned against this, not to take any antacids because it can affect the level and the effectiveness of this drug.
Or even to be on an ARB, an angiotensin receptor blocker,
right?
Because this drug is a dual drug and it's an angiotensin 2 receptor antagonist.
Right.
All right.
So it will further block this.
Yes.
Okay.
So like you said, the main issue is if you don't take Filspari significant and I don't want to prescribe an opioid, but you give an NSAID, you could lead to increased risk of kidney injury or kidney failure.
Yeah, exactly.
Right? And you caused it by prescribing that medication.
Definitely. All right. Let's move on to, what other drugs will affect Filspari? And we talked about the angiotensin receptor blockers.
Right.
We talked about, we didn't talk about the endothelin receptor antagonists. And you can see the names of them there. They all look like basically they're sartans. So what these are for is for pulmonary hypertension. They're antihypertensives. And so we're not going to be prescribing those, but you may see patients who are taking them. And of course, non-steroidal anti-inflammatory drugs have to be avoided, as well as we mentioned blood pressure medications, which can induce hypotension, and anti-acid medications.
So, Jay, we for sure, this patient will be a definite ASA 3 category patient in your office, because here we are taking Filspari for our poorly functioning kidney. And then if they were to be on one of those drugs, which they shouldn't be, for pulmonary hypertension. So 2 different disease states, but a significant ASA risk in your office.
Yeah. So you got to be aware of these. I mean, there's just so many new drugs you have to be aware of. And a good resource, I've got Hippocrates on my phone, and they have a great drug interaction checker. And so if you don't have Hippocrates already, I would recommend downloading it and using that interaction checker as often as you need to.
And, if you could get into the habit of learning the suffixes of these drugs, like Artan, we know that would be an ARB. And of course, like you said, the Sentan right there, SENTAN, those drugs are pulmonary hypertension drugs.
Right. Yeah. They're not given for systemic hypertension, but specifically for pulmonary hypertension.
Pulmonary. That's right.
Yeah.
But if you could really start working and learn the suffixes as well too, it would go so far. And like, as soon as you see that suffix, you know what that is.
Yeah. Exactly. Even without knowing the drug, you know what class it's in.
Just like as dentists, we know what something cane. We know what that is. We know that's a local anesthetic.
Right.
All right.
Exactly. Okay, let's go on to the next one. Syfovre, PEGCETAOPLAN injection. And this is a drug that is used to treat an advanced stage of dry AMD, age-related macular degeneration.
Right.
And so what happens in this disease is and they think it has something to do with complement activation. It causes destruction of the light receptor cells in the retina, usually starting kind of in the middle of the visual field, and it can lead to blindness. And so this is a significantly important medication, because this is not an uncommon problem as we age. In fact, I think I saw somewhere that what they say about at least 10% of the population over age 50 have at least one area of macular degeneration.
Yes.
What they call drusen. Yeah. And this can also progress into what is known as wet macular degeneration. So in dry macular degeneration, basically the cells are destroyed and gone. In wet macular degeneration, what happens is that you get neovascularization into the devoid areas, and the vessels that form are not normal. So they leak fluid and proteins and all kinds of blood, all kinds of things that further worsen the patient's vision. So this is one of those. So what this drug does is it's an inhibitor of complement, which seems to be effective in treating dry macular degeneration, age-related. And so there have been a couple clinical trials of this drug, one called the Oaks and the other the Derby, and they both show at about 24 months in the Oaks study about a 22% reduction in the growth of these lesions, of these drusen. And the Derby study at 24 months, about 18% reduction. And this is when it's given every month. If it's given every other month, the numbers go down a little bit.
Yeah. And Jay, the thing about it, we're going to know somebody with AMD.
Yeah.
All right.
Yeah, I see patients probably a couple times a month that have it.
Oh yeah.
And yeah, so this drug, it's given with in basically intravitreal injection. So it's injected directly into the eye, anywhere from like every 25 to 60 days. And like we said,
Yes.
every month, the more frequently it's given, the more effective it is. But the drug itself can actually cause significant problems too. Can cause all kinds of inflammation within the eye. It can cause retinal detachments. It can actually cause progression to neovascular AMD, which is wet AMD, or may make the patient's eyes very sensitive, very red. And so, adverse reactions like ocular discomfort and floaters and subconjunctival hemorrhage are not uncommon with this medication. But
we can see
that
when it works well in our office, because again, they're going to get the injections about every 25 to 60 days. And so in between the injections, they could be having dental treatments in your office.
Yeah. Yeah. And so, since it's been shown that there's about a 18 to 22% reduction in the lesions of this disease, the benefits outweigh the risk. And so that's why it's used. So let's move on to our last drug, which is Skyclarys or OMAVELOXOLONE.
And so just show you some commonality.
This is another orphan disease drug.
That's right. Just show you some commonality. Just a few months ago, we talked about another drug called Skyclarys for plaque cirrhosis. Okay.
Right. So it's easy to get some of these drugs confused.
Yes.
Yeah. And the fact that, if you notice on prescription bottles now, when they usually type some of the letters of the name in capital. So there's like, if a patient has trazodone, it'll say TRAZ in capitals. If it's tramadol, it'll say TRAM because the names are so similar.
Yes.
So they don't get confused. And so this is another drug that you could get confused with something that has a similar name, but a totally different indication.
So for example, like we said, we've already talked about in the last 5 years, like almost, 600 new drugs came out. Think about the nomenclature, trying to keep the confusion down on that.
Yeah. Yeah.
And we're not stopping with the releasing of new medications, Jay.
Yeah. Yeah. And the names are getting more and more complicated too.
Yes.
Seems like they're adding, and especially the generic name, they're getting more and more complicated. So this drug is, again, it's a first in class that therapy specifically indicated for an orphan disease known as Friedreich's ataxia, which is kind of a form of muscular dystrophy.
Yes.
And it's due to a mutation in the frataxin gene, which encodes for the mitochondrial protein frataxin. And the exact function of frataxin is not really fully understood, but it seems to help to assemble clusters of iron and sulfur molecules that are critical for the function of many proteins in the neurologic system. So this is an inherited neurodegenerative disorder that's usually diagnosed in adolescence as muscular dystrophy is. And the patients will present with progressive loss of coordination, muscle weakness, fatigue. They'll lose motor control, eventually end up in a wheelchair. And in their early 20s, or not much later, they end up succumbing to the disease. And it affects about 5,000 people in the U.S. currently. And what it does is it induces the molecular pathway that will reduce inflammation. So it restores the mitochondrial function, reducing oxidative stress and inhibiting the kind of the pro-inflammatory signaling in the system. So this is, like I said, this is the first of kind, first in class drug that's indicated for this orphan disease.
And like you said, this is in the class of MS as well too. I guarantee you, Jay, that you'll see some spinoffs from this medication with it being first in class and how to treat MS patients as well too.
Yeah. Yeah. I mean, the drugs in these, to treat these neurological disorders are exploding, just as they are in, for treating cancers, for treating all kinds of immune disorders.
Yes.
It's just mushrooming. There's going to be, we had, what was like 200 new drugs last year. Wouldn't be surprised if there are 400 by the time we end 2023.
And the thing about it, to our Pharma Nation, Jay and I are going to keep you up to date on that as well too. Every new drug coming out, you're going to learn from your fellow colleagues, because we're practicing dentists just like you are. We're out there every day in the trenches working.
Yep, seeing patients that have all these disorders and are on these medications. So it's important, even if you're not doing surgery and putting someone under sedation, even with restorative dentistry procedures or perio treatment or endo, whatever you may be doing, or taking out teeth, you've got to know what these medications are and how they affect your treatment and how your treatment is going to affect these medications, as well as prescriptions you may give the patient. And
if you do give some type of prescription, they're on these medications, when you get that phone call at night and they have some type of adverse event going, you know how to handle it appropriately.
Yeah. I mean, the nice thing is with a lot of the electronic prescription systems that are out there now is you enter in patient's medical history, all the medications they're on and the diseases. And if you enter something that doesn't, that's in their system, it'll tell you, you may want to reconsider using this prescription. You may want to try something else because of this interaction or that.
That's great.
That's really helpful.
Yes, it is.
So let us move on to our medical emergency of the month. And the type there is pretty small. So what I'm going to do here is I'm going to get rid of us, because, you guys are probably tired of looking at us. And so we're going to talk today about seizure disorders and seizures occurring in your office, which can occur de novo, first time in your office, or in a patient that has a recurrent seizure disorder such as epilepsy. So about 1 in 100 people in the US have had a single unprovoked seizure or have been diagnosed with epilepsy. And it's estimated about 1 in 26 people will develop epilepsy during their lifetime. And some patients may be at higher risk.
So Jay, right there, that's critical, because you said they had a single unprovoked seizure or have just been diagnosed with epilepsy. Just because you had a seizure doesn't mean you have epilepsy.
Right. It's got to be recurrent.
It's got to be recurrent. Yeah. That is correct.
Yeah. Yeah. So for example, if you have a head injury and you have a seizure, even if it happens maybe one more time and then it goes away, that's not epilepsy. Epilepsy and seizure disorders are something that are with you for lifetime.
And like the next point, 1 in 26 people will develop epilepsy in their lifetime.
Yeah. Yeah.
1 in 26. So, I mean, I'm jumping ahead, but we're looking at 3.5 million people in America today.
Yeah.
Okay.
Yeah. And a good proportion of those are children, about 470,000 of them.
And all those people are probably coming to the dentist, right, Jay?
Mm-hmm. I hope so.
So we're going to have to know how to treat a seizure. And there's more than just one type of seizure as well, too.
Yeah. John, have you had any occur in the office?
I have not.
Okay. I had one, must have been 15 years ago, a woman with a known seizure disorder who supposedly was well controlled. She had a seizure while we were treating her, while she was sedated. So I gave her some IV Valium because that's what we were using at the time to try to break the seizure. It did, and then it recurred, I think, 3 more times. We ended up eventually, calling and her husband, we notified him what was going on, and he said, "Oh, yeah, she does this all the time." And we called the paramedics, and when the paramedics arrived, they knew her.
Okay.
So she, this was a common occurrence for her. So that'll move us on to how do you manage a seizure disorder?
But Jay, okay, I love how you said, okay, what you got the loved one involved, that being the husband. Yes, this does happen, but for reassurance, you went ahead and called 911.
Yeah. Yeah. And of course, we initiated treatment as in this algorithm from the onset of the first seizure.
And plus, whenever you call 911, you don't know when the wheels of life will get to your office. Yeah. This is why you need to start this process early on.
Yeah. Yeah. I mean, if the patient's conscious after the seizure, you just want to, or during the seizure, you just want to make sure that they're safe. You want to keep them safe.
That's right.
Prevent them from falling out of the dental chair. You don't want to stick anything into their mouth while they're having a seizure. But you just want to make sure they're positioned to keep their airway open if you can, without hurting them. The seizure will generally end, it'll subside on its own. And if the patient is conscious afterwards or semi-conscious, then you want to suction out their mouth because they've probably salivated a lot. You want to make sure they're hooked up to vital sign monitors, and you want to make sure you have them on some oxygen, and then get in touch with their physician, which I also did. But if they are not conscious after the seizure, then it's totally different. That's when you absolutely need to call 911 and get that chain going, because you don't know how long it's going to take for them to get to your office. It really depends on where you are.
And Jay, going back to the algorithm underneath, yes, contacting the person's physician. You may also, you will need to contact their loved one or a family member if they're by themselves. You do not want them to leave your office and drive.
No. Yeah, you want that family member or someone with them, even if they're conscious right afterwards.
Yes.
You don't want to let the patient drive home, because a lot of patients, if they're well controlled, and if they don't have well controlled seizures, they absolutely cannot drive. That's probably DMV in every state does not allow that. But if they're well controlled and they haven't had a seizure in a couple of years,
6 months,
or depends on what state you're in.
Which state? That's right.
Yeah. Then they may be granted a driver's license. And of course, if they then have a breakthrough seizure in your office because of what you may be doing to them, obviously you're not going to just say, oh, you have your driver's license, you can drive home. You want to make sure that you contact that family member to come get them. All right. Document. Exactly.
Write all that down. Okay.
Right. So if they haven't regained consciousness, the first thing you want to do, of course, is after you call 911, is you want to initiate your office emergency medical plan or medical emergency plan. And that begins with the ABCs, assessing the airway, whether they're breathing, and if they've got circulation. Now, in the newer guidelines for BLS, you actually check for a pulse first.
Yes.
Because if they don't have a pulse, they're not going to be breathing. So rather than wasting time trying to determine if they're breathing, if they don't have a pulse, you immediately start BLS. And get your AED ready. But if they are still unconscious and you're waiting, they're otherwise stable, their vital signs are stable, you want to make sure that you suction out their oral cavity so that they don't aspirate on their own saliva. And you want to kind of prepare the patient for transport for the EMS. You should have everything documented, so when the EMS shows up, you can tell them exactly what transpires, this patient's medical history, what medications they're on, what interventions you've done since the seizures first started, so that they can basically get them to the hospital, and they will know what's been done, so they can further the treatment there.
So now, Jay, I like to point out again about calling 911. It's very important that you have somebody. One thing Jay and I talk about on our other medical emergency courses, on our emergency response plan, that people are designated certain duties, like your front office people. We call them ROVER, ROVER.
Yeah.
One will be responsible when Dr. Reznick makes the decision we need to call 911. He shouldn't have to worry about, did somebody call 911?
Yeah. There's one person designated to that.
And that's their job.
Yeah.
Okay.
And you need to make sure they call 911 from the back office, not from the front office, because you don't want to create panic in the office. And then, of course, be ready to meet the EMTs at the door to your office, at the door of your building, and escort them up to the office.
That would be Rover 2. Rover
Yeah.
2 would be responsible. And look, you may not have that many employees, so then that means you'll have to combine duties. Okay?
Exactly. So
but it's
now,
got to be coordinated before the event, Jay. If you say, "Oh, I'm not going to worry about having an emergency response plan," it's going to be catastrophic in your office.
Yeah. If you don't have a plan, you're going to have a disaster.
Yes.
And if while you're waiting for EMT, the patient has another seizure, like the one patient that I told you about, then it is acceptable, if you have an IV in them, to give them something to try to reduce the seizure activity, like benzodiazepine. So something like midazolam, 3 to 5 milligrams, or diazepam, 5 to 10 milligrams, as long as if you have IV sedation training. You don't want to do that unless you have IV sedation training, but it really will help break a prolonged seizure, or if the patient's having recurrent seizures.
So Jay, if a dentist doesn't have these medications, then they just have to be there by the side of the patient, protecting the patient as well, too.
Yeah, exactly.
And then hopefully everybody in your office has done their job calling 911.
Right. Yeah. And the big thing to remember is, if there's a drug in your emergency kit and you don't know exactly what it is and exactly how it's used and what it's for, don't use it.
That's right.
You got to be familiar with everything that's in your emergency kit.
Every drug. That is correct.
Yeah. And for a basic kit, there are only about 10 drugs that you need in there.
That's right.
Yeah. And so you've got to know them inside and out, backwards and forwards, up to down, down to up. All right. So,
Jay, back up 2 slides.
Okay.
All right. The last thing, SUDEP. Many of you might be wondering, what is SUDEP? Well, that's sudden death from epilepsy. And 1 out of 25,000 people diagnosed with epilepsy die from a seizure.
Mm-hmm.
That could happen in your dental office.
Yeah. 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 What's usually the cause? Is the just loss of brain function from the seizure, or is it airway obstruction or a cardiac event?
A little bit of the first 2 right there.
Okay. That's what I would guess.
So again, if you're trained, able to try to break the seizure, maintain oxygen on the patient, protecting the patient, calling 911, that patient has a chance of survival.
Yep. All right. So now is the time where we give you our shameless plug for PharmaDent, and
which is going live this month, Jay.
Yeah, we're excited. We've been working on this for
years.
A year?
Yes,
at least a year.
It's going.
Since beginning of COVID, I think.
I mean, seriously, you'll never have to travel to another lecture and maybe get one topic. You're going to get 15 different topics covering a vast array of medically compromised patients.
Yeah, a comprehensive program of all the different types of medications that your patients may be taking, that are in addition to the drugs that we talk about on PharmaDocs, on Pharma Fridays. Okay.
And Jay, what I love about the programs, and of course, everybody can see the modules right there. Yeah. The way they have developed the modules is such a great learning pathway for anybody. I love how once you finish one, you advance to another.
Yeah, it's not just boring PowerPoint slides.
No,
they've really dental learning has done a fantastic job putting this together.
Incredible. And the great thing about it, we already got other modules ready to go in the future. I mean, it's just, and we encourage you to contact us saying, hey, what about this? Would y'all do one on that as well too? But very exciting about bringing this content to you. Yeah.
And we'll also have our DOMES course, the dental office emergencies, dental office medical emergencies simulation plan.
Do you have that slide up there?
Let's see. Oh, there it is. Look at that.
There
it is. So this is about basically medical emergency simulations in your office, so you can do the practice drills in your office with your staff. We talk about how that emergency response team in your office, the emergency response plan, is put together, and then break it down into 4 different modules of 24 different medical emergencies. Six
So
each.
so each module has 6 medical emergencies, but in the introduction, Jay takes you through the 6 links of survival. You got to have that definitely deployed in your office. It goes through the emergency response plan. It tells you about every single person, the reactor, the responder, the retriever, Rover 1, Rover 2. Everybody's duty is spelled out for you on this.
Ahead of time.
Jay, you just did an incredible job on that video. And again, because you know what? So many people, Jay, are looking for a medical emergency lecturer because honestly, you need to have this once a year in your training.
Yeah.
All right.
I mean, live lectures are coming back, but you know, the one thing about a live lecture is you go there and you see the lecture and you remember a couple things from the lecture. And that's it. And the advantage of online courses is that you can go back and review it as many times as you want.
Grab your staff and say, look, let's go through this again.
Yeah,
everybody
share it with your staff.
Like you said, by the end of the day of a course, you've almost forgotten 70% of that material you heard by the end of that day.
In fact, I use this in my office for my staff.
Oh, absolutely.
Review. Yeah.
Absolutely. Because again, if you have a medical emergency in your office, you're going to have to prove your due diligence. Yes, we take medical emergency courses once a year.
Yeah.
Here it is on dentallearning.net.
Yeah. And these modules are only like 30 minutes each.
Yes.
So it's you know, you can do it at the end of your day or before lunch, however you want to do it.
So what we'd like to do is go through one of your medical emergencies, stop, and then just discuss everybody. All right. So you're the responder, you're the retriever. This is everybody's duties.
Yeah. Yep, exactly. All right. Oh, and the other course that we have is
we got to put a plug in for this too, because
opioid course. So
yes.
I think it's 35 of the 50 states now require a course in opioid prescribing and opioid abuse to be taken in order to renew your license. And some states it is an hour that's required. Some it's 2, some it's 3. The specific subjects that need to be covered vary from state to state. So what I did is I put together a 3-hour course that covers all the subjects that are required for every single state in the U.S., including, I think, Puerto Rico too, and Guam. And so you get everything. If you only need an hour, you get more than you need. If you need 3 hours, you get everything that you need in this course. And so this is also available on dentallearning.com. .net. Sorry. .net. All right.
So Jay, I'm real excited about this one because you and I are doing this together, and this is patient dies in your dental office, a medical emergency gone bad.
Yeah.
What happens next? So Jay and I are going to take you through everything that you could be subjected to after a catastrophic negative outcome in your office. Because you will be asked quite a few questions. And Jay, how many did we come up with? At least 60 questions?
Yeah, I think something like that. Yeah.
And it's not just, from attorneys, but also your state board. It could be from governmental agencies like OSHA, the DEA, the OIC. Or it also could be the district attorney there if they think there might be some criminal negligence as well too. Yeah,
John and I have both been expert witnesses on a number of cases, including board cases. So we know what it's like. We've probably been deposed a number of times on cases we've been experts on. We've been in court. So we kind of know how things go there. And the one thing you have to remember is that whoever is against you, so not the attorney representing you, but the other side, their job is to make you look incompetent and make you look unprepared. And Jay, what I like about you got to be able to defend against that.
Right. And what I like about what we've done in this course too, and by the way, this is coming up. All right. Is the fact we've also given you solutions to all of this as well too. Yeah. And when we go through the questions with you, you'll have the opportunity to listen to this and go back to your office, because the great thing about it, this is a web-based course. Yeah. So you'll have time to write everything down. And like Jay said, on the other aspect, you won't forget this.
Yeah.
All right.
You'll be able to go back and review it.
Absolutely.
Many times as you want. Yeah. Okay.
So, and of course, Jay and I've got more courses coming out as well down the road, but the great thing
we're working hard.
Yeah. The dentallearning.net is going to give you everything you need. You don't have to go search out a lecture on pharmacology.
Yeah.
You don't have to go search out a lecture on medical emergency. Why, Jay? Because first of all, they're going to be very rare to find them. First of all,
yeah,
you're not going to find that many of these courses out there.
Right.
So Jay and I have taken our expertise,
especially given by someone who actually is in clinical practice.
That's correct. Great point.
Yeah.
And we are in clinical practice, and we are looking out for your best interests here.
Yep. All right. So that's it. Let me just go back here. So our next whoops, wrong button. Our next episode is April 7th. Again, which is the second Friday of the month, Pharma Friday at 3 p.m. on the West Coast, 6 p.m. on the East Coast, and in between. And we'll be talking about the new drugs that have been approved in March, as well as discussing a new medical emergency. So we hope that you can join us.